All right, everybody, we are talking about GI, mostly liver and pancreas. Those are your fine objectives. The GI system review, right? Little patho for you. From the GI tract, or the oral cavity, all the way down to the large intestine and everything in between. Let's talk about some very important diagnostics. Okay. So a CBC, specifically the RBCs and H&H, are looked at for GI bleed considerations. That's when we'll have some aspects. If we think someone has a GI bleed, we're going to be doing that bedside guaiac test to see if there's any blood in the stool. PT-INR. These are the clotting factors. So if your patient's on Coumadin, if they're on aspirin, they're on heparin, or any of the other anticoagulants, they're at a bleeding risk. Electrolytes, especially when we're talking about the pancreas. The pancreas has a lot to do with potassium. I'm sorry, not potassium, my apologies, calcium. So we'll be talking about that. ALT and AST, liver damage. Amylase and lipase are your pancreatic damage. Remember, amylase starts with an A. It shows up first. That's where we're going to be looking at when it comes to acute pancreatitis. Whereas lipase is late, it's lazy, it shows up later, and that's more of a chronic pancreatitis aspect. Both very good measuring tools, just amylase tends to show up first. Bilirubin becomes elevated when we have liver dysfunctions and a couple of the other GI issues we'll talk about. An EGD, this is an upper scope. The patient would be sedated, they would be intubated for an EGD, and we need to be aware of airway protection during this. An EGD is going to show ulcers, polyps, any type of bleeding in the upper GI. CT scan of the abdomen, we do prefer at least the patient be NPO up 4 hours before so everything can settle down. An ERCP, this is going to look at liver, gallbladder, gallstones, pancreatic, all the ducts that have anything to do with this. A pertinent assessment question, we do give contrast for an ERCP to look at all the ducts. So we have to make sure the patient's not allergic to shellfish or iodine. And then another one that we do tend to do a lot, especially in liver aspects, is the liver biopsy. This poses a great risk for post-op bleeding. So the nurse has to be watching for a hematoma at the puncture site. So there are several different hepatitises out there. Hepatitis A, which is more fecal oral route, not necessarily life-threatening, but it does spread. This is something where we constantly have the patient washing their hands. Hepatitis B is more bloodborne. Hepatitis C is bloodborne. And hepatitis C can infect some for life. There is not a vaccine or a cure for C, which A and B do have a vaccine. Hepatitis D tends to come from untreated hepatitis B. And then hepatitis E, this is typically self-limiting. It is a waterborne infection. So the new aspects with hepatitis E, because that really hasn't been around knowledgeable for a long time, that comes from water and fruits and vegetables that be contaminated. So if you've ever heard, if you're going to a foreign country, at least for a little bit, you should make sure you're washing your fruits and vegetables and drinking bottled water. That is something that we would aspect to do, especially if you have somebody going to a part of the world you've never been to. Then we would want to be making sure we're using bottled water and washing our fruits and vegetables. You should be washing your fruits and vegetables here in the United States too, but that's another conversation. All right, let's talk about liver cirrhosis. Okay, a lot of stuff with liver cirrhosis. There's a couple different reasons someone gets it. Alcoholism is kind of the bias with it, but you can actually just be born with liver cirrhosis and it's a genetic trait, right? We would highly, highly advise a patient not to be drinking alcohol with liver cirrhosis for whatever reason they got it. Even if it's genetic or they got it from hepatitis, liver or alcohol use is going to make the cirrhosis worse. Something else that we see with liver cirrhosis, especially to more of the advanced stages, is the patient can get very confused because of the increased ammonia level, because the liver is unable to filter out the toxin ammonia. So the patient can get really confused. With that being said, there is a medication called lactulose that is given. It's an oral liquid. The main side effect is diarrhea. They're going to have a lot of loose stools. But the assessment key for lactulose is actually their cognitive function. So were they confused before we started the lactulose treatment, and a couple days later, now they're alert, they're orientated, they remember their name, they remember the nurse's name, they can follow commands. That would be something to show that the lactulose is working and the ammonia level is going down. A lot of times with liver cirrhosis, we also get something called ascites. Ascites are buildup, like think of little water balloons inside a large beach ball. The beach ball's the abdominal cavity, and the little balloons are filled up with toxic fluid because the liver was unable to filter it out. So it made these little balls of ascites. What's also in those balls of ascites is albumin. So the patient's albumin level will also go down. So you'll see liver cirrhosis patients very often getting albumin. And albumin is that thick, sticky liquid. A lot of the times it's in a glass vial, but you can see it in just a regular 100 milliliter bag too. If the ascites is getting really bad and we're not managing it well with the lactulose, the physician may opt to do something called a paracentesis. This is where he's going to go in with a large bore needle and he's going to empty out the balls of ascites, called a paracentesis. Something we're going to do right before we do this paracentesis is have the patient empty their bladder, because the bladder is right next to the pancreas, and we don't want a full bladder because it could kind of get in the way of where the ascites are. So we want the patient to be able to empty their bladder right before the procedure. Hopefully this patient will be able to get home. It's not an end-of-life care all the time. And so some things that they're probably going to be doing at home. It's very common that this patient's going to be on a dose of Lasix every day just to keep the fluid shifting through the body and going out the body, so it has a less chance of developing severe ascites. They're going to be on a low sodium diet, and we're going to teach them how to measure their abdominal girth, because sometimes the ascites can start to grow without much outward sign symptom other than the area of the stomach where the liver is kind of gets a little swollen. So there's some things that the patient's going to want to do outside of being in the hospital. We also would like them to weigh themselves daily, because a couple pound weight gain overnight can really show us that maybe there's an ascites building up or we need to do some more intervention. When you have a patient with cirrhosis, the early stages are kind of vague. They might be a little tired. They might be a little anorexic. They could have some dull abdominal pain over the liver on that right upper quad. The later stage, that's when you're going to see the jaundice. You're going to see that yellowing of the sclera, the gums, the face. Those are the later stages, okay? So it is very imperative that a cirrhosis patient does not intake any alcohol. This can speed up the process and it also causes a great deal of pain. So we just want to make sure that we're emphasizing that to the patient. When they are home or even in the hospital, they're going to have small, frequent meals so we're not overtaxing the GI tract all at one time. They're going to be on that low sodium diet, that fluid restriction. Cirrhosis patients are at a great risk for something called esophageal varices, and we'll talk about that more in a second. But esophageal varices procedure that is done quite a bit. It's called TIPS, or transjugular intrahepatic portable system shunt, and that's why we call it TIPS. This is where we actually go in and we can cauterize or cuff any of the bleeding from the esophageal varices. Something not on the slide that you might want to jot down is something called a Blakemore. Blakemore is spelled B as in boy, Lakemore, tube, Blakemore tube. And what happens if the tip procedure doesn't work or there are areas we couldn't get to that day, the physician could put this Blake tube in and this will collect the blood. So kind of think of it as like a JP that we put in there, but it is on the it does come to the outside so we can be watching it. On to portal hypertension, which is a very serious complication of cirrhosis. My apologies, cirrhosis. It increases the pressure in the portal vein, which then pushes blood back into the spleen, causing the veins in the esophagus, stomach, and intestines to dilate, causing bleeding. So this is a very critical complication. This can cause greater ascites. This can cause the esophageal varices, and it can mess with more liver function, and it can mess with the spleen and enlarge the spleen, making the spleen not work correctly. So we talked a little about the ascites. So again, this patient, before we do any type of paracentesis to remove the toxic fluid in the ascites, we want them to empty their bladder. Paracentesis is not a rapid procedure. It's slower. We don't want to cause a fluid shift or cause hypovolemia. And even though the fluid's in the body, ascites, the fluid inside the ascites is not in the circulatory system, so the patient's already at a great risk for hypovolemic reaction. And if we pull the fluid from the ascites out, we could actually send them into hypovolemic shock. I've had some physicians put a tube in and we just slowly let it drip out using gravity, and the tube itself is a smaller diameter because we don't want to cause a major fluid shift. So some more stuff about the esophageal varices. Okay, so we talked about the TIPS, the transjugular intrahepatic, um, the TIPS, okay? And we talked about the Blakemore. Some medications that are used. Inderal, which is a cardiac medication. It is a in the blocker family, is used to decrease pressure that bypasses the liver and goes around the spleen. So Inderal can help prevent portal hypertension and esophageal varices. Another drug you might see quite a bit when we're dealing with cirrhosis is something called Protonix. I'm sure you're familiar with it. And this prevents irritation of the enlarged veins, and it decreases acid production in the GI tract, which helps then prevent portal hypertension and esophageal varices. So it's very common to see the patient on those two medications. So, like we talked about the treatment, the Blakemore tube can be done if the EGD is unsuccessful and we weren't able to complete or do the tips at all. We're going to be watching hemoglobin hematocrit go down. We're going to be watching for stool in the blood. If there is stool in the blood, the physician may do an upper and lower GI scope to do any cauterizing that may be needed. Once it gets a little more advanced or the treatment hasn't started working yet, you may see something called hepatic endotheliopathy. This is when there's neurological changes brought on by the untreated liver disease or by the advanced liver disease. This is when there's so much toxic buildup, it travels to the brain. It can make the patient incredibly confused. The ammonia level shoots up, the ALT and AST shoot up. You can even see the amylase and lipase go up because it could be affecting the pancreas. Early stages, the patient's a little sleepy. They could have some mood disturbances, a little bit of confusion, but you're able to redirect and reorientate. Later stages, they're completely lethargic. They are not ANO times 4. Most of the time, they know who they are, but they don't know anything else going on. You could see neuromuscular issues, so you could see uh, muscle shifting, you could see spasms, you could see something called acroaxis, which is like impulse control issues of the hand and the upper body. It's like where the muscles just relax very suddenly, and you can just see the arms and the arms and the hands just drop down, and that is a pretty significant late stage of HE. Like we talked about a little bit ago, lactulose is the treatment of choice. Um, we're going to give it 3 to 4 times a day orally, and the goal is to get the same amount out per stool. So 3 to 4 stools a day. It is going to cause loose stools, but remember, loose stools is not the assessment to see if the lactulose is working. The assessment to see if the lactulose is working is the patient ANO times 4. Or are they alert and oriented more than they were when we started? So if you started a lactulose and they were only alert to themselves, they had no idea what was going on. You give it a day or two. Are they aware they're in the hospital? Are they aware that you're the nurse? You give it a couple more days and now they understand that it's a liver issue. There should be a progression. If you do not see improvement, we may be in more of an end of stage care aspect. Other treatments you'll see will be aspects of decreasing protein and ammonia. So we can use vancomycin. You might want to look up those labs on vancomycin. We can use Flagyl, which is another pretty good antibiotic, and safety interventions, fall precautions, sides of 2, 3 side rails up, constant orientation, possibly a sitter. I've had family members take shifts. If that's hospital policy is okay with that, go right ahead. And then we have something that we call HRS. This is where the liver function has progressed and now it's so poor that there's not enough blood flow getting to the kidneys. So then you actually start to see kidney issues. So you'll see a sudden decrease in urine output. Their BUN and creatinine will be elevated. Their serum osmolality will be elevated. Their GFR will be elevated. This is an end of life situation. Um, the only thing that really can be done for these patients, if they would survive it, would be a liver transplant. Along with that, we would be doing dialysis too to help the kidneys do their job until the new liver can get involved. So I've had patients get a liver transplant and do pretty well, but it's really hard to get any type of organ transplant, especially on such a short time frame when HRS kicks in. On to liver transplants. We don't need a whole liver. I don't know if you guys knew that. You don't need you could actually be a live donor. You could donate part of your liver for a liver transplant, and we can use cadaver livers, which is a newer aspect too. The liver lobe we put in a new patient will grow, it will regenerate, so that's why we don't need a whole one. And if you give one as a live donor, your liver will also generate and keep going. A lot of complications with the liver aspect. We have a lot of clotting issues, infection issues, rejection issues. You're going to see that with a great deal of different organ transplants. But we are going to be, we are going to be doing close assessments on a liver transplant because we don't typically see a vital sign shift if the new liver starts to reject. We actually see signs, symptoms of the flu. So all of a sudden the patient will just be progressively sweating, maybe not like drenching their bed, but you always notice they're kind of shimmering. They always have a couple little drops of sweat on their body, and they'll also be really cold. So they're kind of like having the flu. We have to be mindful after a liver transplant. There's several things that the patient cannot be taking. They should never be taking Tylenol again. They should never be drinking alcohol again. And if they have any history of gallstones, gallbladder stones, it's very common that the physician will actually just take out the gallbladder to prevent this complication from happening from the buildup. Because if you don't have the buildup in the the gallbladder, what will happen is the body will send the bile into the GI tract and just get rid of it, and it'll just go into the stool. All right, on to your beautiful little pancreas. Acute pancreatitis. Acute pancreatitis is incredibly painful. This patient's going to be side laying. They're going to be in the fetal position. This patient is going to be immediately made NPO because we've got to get the gut to heal. A lot of times you'll have the physician order putting an NG tube down into the stomach so we can decompress the stomach. You decompress the stomach, you relax the pancreas. So the patient, after you put an NG tube down, the pain for the patient should be decreasing. It will not take away the pain, but the level of pain should be coming down. Labs that we look at for pancreatitis are amylase and lipase. Amylase, that's the first one that's going to move. That is the one that is going to go up first when there's a problem. It's going to come down first when treatment is working. And lipase you'll see elevated a lot of times if you have a patient fighting a chronic pancreatitis issue, which we'll talk about here in a second. Something you'll also see in acute pancreatitis, you watch those calcium and mag levels. They're going to drop. So if you do not remember the signs, symptoms of low calcium and low mag, you may want to go look those up quick, okay? Just refresh yourself. And look at your assessments for that too, okay? So you want to look at the abdomen and the flank side for the Gray-Turner syndrome or the colon sign, where they can get the bruising, the discolorization from the pancreas being inflamed. So like I said a minute ago, NPO is the first thing we do. So we take everything away from the patient. No food, no drink. I have had physicians have them so strict because the prognosis was good, but they couldn't even have like ice chips. I had one physician that wouldn't let his patient even brush his teeth because he didn't want him swallowing any water. Okay, so I'm like, well, okay, that's a little strict, but it's true. So to keep them nourished, though, we can do IV hydration. If it's great deal of days, then the physician may consider putting a PICC line in for TPA, and that will give us all our fats and our lipids and our electrolytes that they would need. Depending on how well the patient's doing with treatment, how the pain is, How the labs look would depend on how long that NG tube does stay in. If they're still having some nausea issues, we can do antiemetics, your Zofran, your Reglan, and some GI meds to decrease gastric acid. So one of the big ones you'll see them on a Protonix drip, and Protonix drip decrease the acid production. And occasionally we do check the stools just to make sure that there's no blood in the stools. And if there's no blood in the stools, we kind of know that the Protonix is doing its job. After it's controlled, especially for going home, we want to start the patient on food, usually clear liquids first, and just real small little meals. A little glass of water. When they go to foods, maybe a little bit of applesauce, nothing that's going to awake the GI tract too fast, too long, okay? We're going to have a lot of bland foods too. They should not have any caffeine. I know, not my idea. Nothing too spicy that will inflame the GI tract and get the pancreas upset again. Absolutely no alcohol and no smoking, because smoking can activate the pancreas also. Complications of pancreatitis. We've talked about the hemolytic shock related to dehydration. That's why it's very important that they're getting hydrated once they enter the hospital. They could go into septic shock. If they get infected and it goes into Sayers, and we're watching their vital signs and their white blood cell counts are going high and their H&H are going low, we should be looking at sepsis protocols right now. We should be digging into a little bit more, because what we've been doing isn't working, or maybe the patient, this is the first time they've gotten treatment for it. Okay. Acute pancreatitis can complicate flow to the kidney, so we could have an acute kidney injury. Thankfully, if you start hydrating the patient, typically the kidney injury does start to resolve itself, but we want to keep an eye on that BUN, that creatinine, all this stuff goes together. And very often, pancreatitis can lead to diabetes. The pancreas is inflamed, it's under attack in its own, it's eating itself. So it could stop producing insulin, or it could decrease the production of insulin. It could be a temporary, we're giving the patient insulin for a little bit of time until we can get the pancreatitis under control. It could end up being a chronic condition, and now they have been diagnosed with type 1 diabetes, and it can be a lifelong thing. If the patient is jaundice, we're looking at just a bile duct obstruction. If there's a bile duct obstruction, you'll see a doctor probably do an ERCP, go in and take away what's ever obstructing the bile duct, and then the jaundice will resolve on its own. Chronic pancreatitis. Unfortunately, alcohol abuse is the primary risk factor, and this isn't like someone that's having a single glass of wine at night or a couple beers or a couple drinks in the morning. Okay, I mean in the morning. Well, maybe they're night shift worker. They have it in the morning. I meant the evening or on the weekend. So okay, this is just a chronic issue. Maybe they have a lot of stones in the bile duct. Maybe they need their gallbladder taken out. Sometimes that can rectify the situation. But there's going to be a lot of pain management going on. They're going to be on a lot of powerful medications to focus on that. There is a medication that is on the market, and it's been on the market probably good 10, 12 years now. It's called panolipase. And it does a fantastic job of assisting the bile ducts in moving all the enzymes through. And they should be taking the pancreolipase right after they eat. So when they eat a meal, and after they're done eating, they take the oral tablet. And it is proving to be very effective in chronic pancreatitis patients. With that being said, if the chronic pancreatitis is from alcohol abuse, as soon as that patient has a drink, there will be a massive flare up and they'll go into acute pancreatitis. So it is very, very, very important that they do give up alcohol. Pancreatic carcinoma, better known as pancreatic cancer. There isn't a whole lot of treatment. This is a very deadly disease, and it has a very high rate of patients passing away. There's no surgical management because you can't live without your pancreas. So we do fight it with chemo and radiation therapy. Physicians can put biliary stents in to help with different enzyme flow, but it's going to be a really big pain management. There is, if there's more aspects of what's going on with the pancreas, there's a surgical procedure that's called a Whipple. Okay. Um, we remove part of the pancreas. You cannot remove the whole pancreas, but you can remove part of the pancreas, the duodenum, part of the stomach, distal bile ducts, and a lot of times you'll see the physician take like the gallbladder out, take the appendix out, anything else that could cause an issue. Um, And this does have a pretty good success right now. There is a physician in Milwaukee, a surgeon. I think it's Dr. Thomas. I might be getting his name. I met him one time. I've never worked with him. I met him. And one of the big surgeries he does, and one of the only surgeries he does now in Milwaukee is a Whipple procedure. He has people come from all around the world because his success of his percentage of success is quite high. So I've done a couple of these at the CTCA, and it is a very long procedure. But if it's done right, the patient does have quite a long time left living with us. I've had patients after this procedure done live. They're still alive, and it's been 10 years from what I remember. So but it is quite a procedure. When this procedure was first rolled out for patients to have an option with, the success rate just getting out of the OR table, just getting off the OR table, they had about a 50-50 shot. Now, almost no one dies in the OR, and I want to say Dr. Thomas's success rate, which is anybody that has it lives over 5 years, is about 75%. So it's getting better. All right, what I'm going to do is I'm going to, when I email this out, I will email out the answers to the questions so you have them. I will do a review when I come back in November. I'm only going to be gone one day. And we'll still do another tutoring for exam 5. So please, if you need anything, just send me an email and I'll be more than happy to help.